my talk is going to be a lot more practical in terms of how to prepare yourself, how to understand what happens in a typical office visit with Parkinson's patients. Okay, so this is coming. So when we don't like the doctor today, he was a little cold, he walked in and out quickly. The new AI, the new intelligence systems, you're going to have a robot who's going to come in and probably take care of us, not too far into the future. But so that's the plan for in a lot of hospitals and doctors' offices, that this will be robotic. So I was hoping to have the slides right here so I could read them, but so how do you prepare for an office visit? Very practical. We're in time constraints these days. The doctors are being rushed by the hospital administration to see more patients, do it faster, do it more efficiently. And patients with Parkinson's have a lot of things to talk about. So if we're organized, we try to get organized, and we come in with a list of things, I think that's the best way to do this and get through it in a timely fashion. So you want to make a list of all of your problems and questions and bring a diary if you have one. Prioritize your list. What's the most important to you to solve or discuss with the doctor? Yeah, and don't be nervous. Don't be embarrassed about any issue you're having, because as you heard today, Parkinson's is not just about the motor symptoms. There's a lot of non-motor features, and can range from your mood to bowel and bladder function to sexual functioning, which can be affected. I mentioned them up here. Even sometimes as a side effect of the medications, there's something called impulse control disorders. Thank you. I could hear it, I was getting dry. So impulse control disorders, which could be problematic, like gambling, shopping too much, and eating too much, sexual compulsions, those can be side effects of some of the Parkinson's medicines, most particularly the dopamine receptor agonists, which include Mirapex, Requip, and Nupro. And we just have to be aware of them because it is dose-related and can be reversed just by altering the medications. So when a person comes to see me in the office, I kind of base this on what I would like. I want to hear it all. I don't want to have to drag everything out of a patient. But I can usually tell by observing them that they're holding something back, and I do dig in sometimes to get the full story. If not, sometimes the spouse or caregiver will give me the story. I would like all patients, and I think I haven't emphasized this enough in my practice, to have patients bring all of their medicines in the original bottles with them when they come to the office. So I can really make sure that I know what the patient is taking. It is not a good idea to sort of, maybe I'm taking this or that, and I want to make a change in your medicines. If I don't know what you're really taking, that could be causing a bigger problem than what we're trying to solve. And the easiest way to be sure that I know about all of your medicines, not just Parkinson's, is to bring a bag with you with the pills in and with the bottle so I can see the labels. For example, if somebody didn't tell me that they were taking Compazine for their nausea, and I didn't know that, and I saw the symptoms were worse, I would increase their Parkinson's medicine, where in fact, Compazine blocks dopamine and is really shouldn't be used in Parkinson's patients. Another drug, a GI drug, is Reglan, which is a motility drug that blocks dopamine and makes the Parkinson's worse. And so I need to know those things. Otherwise, I'm going to be creating bigger problems. So when you bring all the medicines, it really clarifies what's going on. And then I want to know what's happened since the last visit. Have you gotten any therapies, physical, speech, occupational therapy, how's it worked out, has it been helpful? Any illnesses, any treatments that you've gotten, were you hospitalized since the last visit? All those things, you know, we can have on a nice sheet of paper ready to go for Dr. Rezak, so we can really get to it and we can figure out what we're gonna do to help you. So sometimes it's better, you know, I said all these things, you can find a lot of suggestions for preparing for your office visit on the internet. There's a lot of different approaches. But sometimes to make it live for everybody, a case study is a good way to do it. I'm gonna have to turn because I don't have it here, so pardon my back. So Mrs. Smith, she's had Parkinson's for 8 years. She arrives for her first appointment with Dr. Jones. He's a movement disorder specialist. Of course, she's very excited and wants this to go well. She wants some help for her symptoms. She's been getting treated by her internist, her general neurologist, but really hasn't had a specialist. She's about 10 minutes late for her 45-minute appointment. Not a good thing. She got lost, maybe. Maybe the building was confusing. She couldn't find her way there. But the bottom line is she's late. Then the nurse brings the patient back. They call it rooming the patient, and they do the vital signs, and we're already even more behind. She brings no records with her. So 8 years of having Parkinson's disease and having different treatments, it's rough. The new doctor needs to know what you've been treated with. What kind of reactions have you had to the medicines before? If he doesn't know that, or you don't know that, then we're destined to repeat problems that we've had in the past, side effects of medications. So, doctor says, what Parkinson's meds are you taking? The patient says, 2 blue pills and 1 yellow pill 3 times a day. Now, this is true, this happens. The husband argues. He says, no, it's a green pill and 2 blue pills 4 times a day, and they argue in the office. This is not a productive thing. I usually cut that off and hope for the best, but you can see where this would be a problem for the Parkinson's doctor, the neurologist. The doctor asks, when did you take your Parkinson's medicines last? The patient doesn't remember if she took her meds today or not. Yeah, I mean, this is very hard for the doctor. You know, we don't know exactly what to do. We don't know if we're seeing what kind of symptoms we're seeing. Are they related to not taking your medicines, or is it really the Parkinson's that's problematic? We don't know. The doctor says, what are your most bothersome symptoms? You know, with the Parkinson's, the patient says back pain, hemorrhoids, and being overweight. Very common. You know, this is, I'm not exaggerating. So the doctor redirects the patient and asks about Parkinson's specifically, what symptoms are bothering you? And the patient says, well, shaking in my legs. And when I ask, or the doctor asks, when does it happen? You know, because you want to get a timing of this and how it relates to medication ingestion. The patient says it's all the time. You know, it just happens all the time, which would be unlikely. And then shaking in the legs, and this comes with under the heading of education for patients. You know, shaking could be a lot of things. Is it a dyskinesia? Is it extra movements, Michael J. Fox kind of movements, or is it a tremor? So, and often patients cannot tell you. I think it's important, as mentioned, and for obviously you're here, to be educated about these things, because when you call the doctor and you're having a problem, let's say it's on the phone even, and you say, I'm having a lot of tremor, it's important to be sure that actually it is a tremor and not a dyskinesia, because the treatment actually might be opposite for each of those. So education about what these symptoms are, what they represent, what their phenomenology is really important for patients and doctors, so we can all do better. So the doctor is frustrated while he is continually typing on his computer, which is another new difficulty that we have. We have this electronic medical record, there's computers in the room, and theoretically doctors are typing while the patient is talking or telling you things. So we don't really observe the patients as well as we should sometimes. I don't bring the computer in, I'm from the old school. But in a lot of situations, somebody's typing, the doctor or an assistant is typing at all times. So the doctor, after hearing all of this and getting no real solid information, is thinking, okay, this patient is going to be a challenge. And the patient picks up on the doctor's demeanor and says, I don't like him. He thinks I'm stupid, but I'm scared and I don't know what to do. I'm overwhelmed. So there's problems here in this office visit on the doctor's side and on the patient's side. And if we want a good, productive office visit, we need to eliminate. The patient needs to be organized. The doctor needs to look at the patient in the eye, observe the patient, and see what is he seeing here? What is going on? What are the movements like? I look and see how a patient sits in a chair. Do they have any spontaneous movements? Are they sitting very rigidly, but they're staring into space? What is going on? So if the doctor is looking at the typewriter, the computer, the whole time, it's not good. I mean, talk about doctor-patient, patient-doctor relationships. This is not a good way to do this. So continuing, the doctor says, he examined the patient. He says, you have stage 2 Parkinson's with dyskinesias in your legs. That's what he determined. The patient says, how did I get this? And what are dyskinesias? Well, the doctor briefly discusses genetics, environmental causes, and then he goes into his spiel about the neuroanatomical pathways and some of the pathology that's there. He says, the basal ganglia, he talks about the direct and indirect pathways. He talks about the substantia nigra, caudate, putamen, globus pallidus, fiber tracts, and all these things. Of course, the patient is cross-eyed by this and not relevant. It's jargon. We do not want to talk to our patients using technical jargon. We want to talk simply, explain things, but not have to go through this. He didn't have to do this. So the patient is thinking, oy vey, what is he talking about? The doctor is thinking, I'm short on time, but I really impressed them. So this is potentially what goes on. The doctor could not make any final recommendations because he didn't have enough information. The patient is very disappointed. She traveled an hour to get there, and he didn't do anything to help her. She leaves more confused than when she arrived. She's trying to figure out the neuroanatomy of the movement system, and she says, I'm never coming back. The doctor thinks, wow, I finished my note and ended the visit on time, even though she was late. He's very happy, and they go about their merry way. And so that's a bad office visit. It really is a bad office visit. So I hope I don't have to tell you why it's a bad office visit. You can see there's no communication here. There's no discussion. There's no understanding of one another. And it's important for the patients to know that doctors are under some constraints, and doctors can only do so much, only have so much time. On the other hand, patients need to bring in their information, be organized, and doctors need to pay attention to the details, the important things, which is understanding the patient and looking at emotional side, not just the motor side. So, imperfection of the office visit for the Parkinson's patient. For the doctor, the problem is going to be he has a fixed time for the visit. Patient arrives late, this last one. It really puts him behind the 8 ball. He feels a lot of pressure. That's not a good way to start. So I would advise patients to come at least 10 minutes, 15 minutes early. There's usually some forms that we fill out, like a review of systems that helps the office visit go quickly. But coming late, it really sets things back. Sometimes, as in this case, the patient didn't know what medication or alternative strategies they were using. And often, patients did not follow through on previous recommendations. Maybe I'm seeing the patient every 8 to 12 weeks. I said to take the medicine in a certain way and maybe get ordered physical therapy. Patient never did it. That's frustrating. That's a problem. Patient did not prioritize accurately their problems. You could see, was it a tremor? Didn't understand the problem, didn't prioritize the problems properly. Hemorrhoids is not one of the things that a Parkinson's doctor would necessarily address, but it could be related to constipation. I mean, the doctor would dig into that, so to speak, but it really isn't what he wants. He wants to talk about motor and non-motor features, and patients need to deliver that information in a concise way. It's not that hard to sit down and think about it before you come to the doctor's office. Patients can keep a diary. This patient did not keep a diary. Diary is, I take my medicine at 8 o'clock, at 10 o'clock I developed dyskinesias, but by 11 o'clock I was off. I couldn't move. And then I had to wait a whole nother hour till I took my next dose, and then an hour later I got dyskinesias again. If the doctor sees a pattern of when these motor symptoms occur in relation to their medication timing, they can do something. They can make a change. We can logically make a change in medications to cover the difficult areas. Another thing is, in common, there's disagreements between the patient and the spouse or caregiver. It really bogs things down. It doesn't help the doctor because we don't know what the truth is, and we try to minimize that. I mean, I stop that right away, but I think it's important for everybody, before you come to the doctor's office, to have yourself organized, because Parkinson's is not just the movement part. We have all those non-motor features. We need to know about all of those things if possible, and try to keep track so you can be efficient when you come to the office. So the basis of a good relationship with a doctor and with the patient is built on trust. And I think here are some of the things that we can do to build the trust aspect. For the patient, be organized, be educated, be bold, don't hold back. If there's something that's going on, let's say a patient's having impulse control problems, and it's embarrassing to talk about something because it's sexual impulse control, eating, whatever it is, shopping. People don't want to talk about it, but if a doctor doesn't know, it can't be fixed. And many of the problems that we have are related to the medications or the Parkinson's symptoms themselves. So we have to know. So the patient needs to be empathetic to the doctor, kind of understand what they're going through, communicate. These are the next 2 bullet points. If we don't know what's going on, the doctor cannot help you. And then you have to listen. Listen to what the doctor is saying. And argue. If you don't agree with what the doctor is saying, or you think it's impossible or they're wrong, discuss it. Not argue necessarily, but discuss it. The doctor, I think this is a big problem these days, has to focus on the patient, not on the typewriter or the computer. They need to have eye contact with each and every patient and caregiver or spouse. So really important. The doctor needs to be observant. I mean, I see more things within the first 5 minutes of an office visit than, I actually can figure out what's going on in the first 5 minutes and have a plan ready as the details emerge, which sort of verifies what I was thinking. But really important for the doctor to do that and to be empathetic. I mean, the doctor's under pressure, and not a good excuse, but the reality is the hospital systems now are such that doctors are getting shorter and shorter amounts of time. They're just by the hospital administration, to see patients. And part of that is related to reimbursement from insurance and Medicare and all these things, so people are being, so the squeeze is on. But it does not, it doesn't justify rushing a patient through, not hearing the whole story, or only attending to one of the 4 problems that the patient is experiencing. I've heard it say that, well, if the patient has more than one problem, they should come back for another visit in 2 weeks. That's not acceptable. It's hard enough to get there for the first visit, for any visits, because of mobility issues, transportation issues, and other things. So we really need to, all of us, on both sides of this office visit, be more efficient, and I think the compassion component can still be there, even with all the business stuff that's going on in the background. The doctor needs to listen, that's important. If he doesn't listen, he's not going to figure out what's going on, and he needs to listen more. And then communicate. Tell the patient what you want them to do and how you want them to do it, and be precise. I think telling a patient, well, we're going to start you on carbidopa, levodopa 3 times a day, and that's it. Well, that's not good enough with this. We need timing. Timing is very important with our Parkinson's medicines. 8, 12, and 4, or whatever the intervals are based on the examination, that needs to be enumerated and discussed with the patient, because I've had patients come to me who have seen other doctors 3 times a day, so they take it at 8, 4, and before they go to bed at 10. That's a huge gap. The drugs only last so long in your system, in your brain. There's a half-life that is measured, and so the precision, the detail of the instructions that we give our patients is very, very important in Parkinson's disease especially. I think with blood pressure medicines, with some other medicines, you could be a little more lax, but with Parkinson's disease, timing is really everything that we need to, and then patients need to understand that. And then, I think this is my last slide, but when I'm in the office with the patient and their spouse or caregiver, I really try to pay attention to the caregiver or spouse, who are usually one and the same, because it's not easy. This is taken from some survey by a Parkinson's organization asking caregivers how to describe what it's like being the caregiver for a Parkinson's patient. Challenging, sucks, unfair, torture, awful, hell, going through this whole thing. And it's important for us, doctors, and patients and caregivers to pay attention to the caregiver, because without the caregiver, everything crumbles. And caregiver burnout is a big problem in Parkinson's disease. So we need to be able to shore things up for the caregiver, make sure they get some time to themselves so they can go to the barbershop, beauty shop, they can play tennis for an hour or so, whatever, go to the book club, because otherwise it becomes untenable. And what happens is the frustration levels rise, the empathy for the patient goes way down, tempers are short, and it becomes very difficult for the patient and the caregiver. And the guilt that comes from that for the caregiver is great, and we've dealt with that before. So I want to put that up there because we cannot forget about the caregiver within the office visit. I'm hoping that we can develop a caregiver support group. That's one of the things that I think Susan has talked about, and I think it would be extremely helpful to have at least some point every month meet and discuss things and have somebody help with coping strategies, maybe getting help. We have some organizations here that work to find help in the house to give the caregivers a break, and that's really, really important. might be my last slide. Yes, it is. So I'll stop here, and I thank you for your attention. I guess we will, I guess we can take some questions if we have any. Anything that I can help answer at this point? All right, so the next office visit that you go to is going to be efficient, sleek, and happy. Oh, there's a question. Okay, yes.
Do you have a checklist breakdown into quantified specific choices?
I'm not hearing. Can someone repeat that?
It's about a checklist.
If you have a checklist and broken down so that you can follow it.
Broken down.
Yeah, sure. I mean, yes, we do have a checklist, and I'll share it with Susan, and she can pass it out. But I think, a lot of the organizations are pushing this, but it really, I was given the task of how to have a happy office visit, how to describe that, and I think these are the things that really make things, I sat back and said, how am I going to, this is not something I even think about usually, but as I went back and I looked over a couple of 3 weeks of office visits, I kind of put together in a case study several events that took place in different office visits. It's very hard when people come late. I mean, some offices have a policy, if somebody's 15 minutes late, they have to reschedule, because it's really not fair to the next patient because then they're delayed in being seen. I try not to do that. There's a question, yes?
Forgive me for putting you on the spot, but Dr. Mitchell was talking about different kind of tests that she looks at, is interested in. I'm wondering how many tests and screens like nutrition that you look at before you see a patient.
All right, somebody can repeat that for me?
The lab tests that Dr. Mishley was discussing, how many of those do you have done before you see the patient?
Yeah, so how many of those tests, I don't know that I would do all of the tests that she described, but I don't order tests until I see the patient, because sometimes people come in with a diagnosis of Parkinson's, and it turns out not to be Parkinson's disease. It could be a drug-induced Parkinson's, it could be dementia, like with Reglan or Compazine. It could be something completely different related to strokes. Or it could be one of the Parkinson's syndromes, the atypical syndromes that may be there. So I have to see the patient, evaluate the patient, and then we decide what tests we're going to order.
What's the difference between Parkinsonian and Parkinson's?
What's the difference between Parkinson's? So when we talk about Parkinsonism, okay, that's a generic term. Parkinsonism is like somebody saying, I have a cold. There's different kinds of cold. Is it upper respiratory? Is it a virus? Is it a bacteria? Is it a urinary? But with Parkinsonism, big-headed, generic Parkinson's disease is one type of Parkinsonism. Multiple system atrophy is another kind of Parkinsonism. We have other Parkinsonisms. I think Parkinson's disease is the most common, but it's important for us to know what we're dealing with, because the treatments will differ and be more or less effective depending on what the diagnosis is. I don't know if that helps. But yes?
Excuse me, is there any new advances in cures for Parkinson's?
Say that again?
Is there any new advances in Parkinson's, a cure for Parkinson's?
Well, there's a lot of work being done in the talks given this morning. We talked about some of those. Dr. Isaacson, Dr. Mishley talked about these. We're not there yet. We're hopefully getting there. We are learning more and more about Parkinson's. I think my comment for the cure would be, I think some of the potential treatments that we've tried before have not been effective, that statistically they haven't been significant enough to say that they work. The problem is, you heard, there's a lot of different causes for Parkinson's disease. Is it the GBA mutation? Is it the LRRK2? Is it sporadic, environmental? Who knows? But because we lump all of those people with all the different etiologies for their Parkinson's disease in one study, and we apply one potential treatment, it turns out not to be effective. I think we need to have what's called these days precision medicine, which means let's take all the GBA mutation Parkinson patients and use a treatment for them, because that may be what we have to do. Otherwise, it gets lost in the mix with all the other different kinds of Parkinsonism. We need to have precision types of clinical trials, and I think that is happening.
Very much, Dr. Rezak. You know what we're going to do? We're going to take all the Q&As